Good morning, good afternoon, good evening, everyone. As Priya already introduced me, I'm Rat Panyowat. I work for Thai Health Information Standard Development Center, and I'm also the SEAL Thailand member. So, as Priya mentioned, this webinar is like a co-event between the FHIR introduction course. I'm not sure how many of you are in this course, and it's also like the event that published to any AeHIN member can join, right? So to give you a bit of background, this is the third webinar. The first two is the Q&A session since the July 6th and July 13th that we already finished. And this is the experience sharing webinar, so that the participant in the course, after they learn like a theory, they can see what it look like in the real world situation to implement FHIR. And it's the experience from not just my country, but another country from COIL as well. And thank you very much for our friend from Taiwan, Philippines, and Sri Lanka for joining to share their experience in this session. All right, so I will begin with the from outside Thailand experience on FHIR. Actually, at the moment in Thailand, we have several FHIR projects going on, but most of them are just like creating an implementation guide, but not actually implement it yet. The one that have an implementation guide and is somewhat implement is this one. Is the consolidating the claim dataset into HL7 FHIR project. So that's why I choose this project to talk about. And a little bit of the background is that in Thailand, we have several medical schools, and 8 of them have formed some kind of a network that they want to exchange the information of the patient. The main purpose is for the research purpose, but maybe other purpose as well. But for now, it's the research purpose. And they don't want to pull the data into the center. They want to keep the data in their control in each hospital. But they want to have an application that can query from all of the hospital in the, let's say like query for a patient to be in the cohort of the research, something like that. So they decide that FHIR seemed to be the standard that's suitable for this use case. But if they want to communicate with FHIR in every detail, because all of them use, each of them use different hospital information system, and to convert an existing data into FHIR in most data, that would take a lot of effort and resource and time. So they decide that maybe it's better to create some like a quick win approach that they can show to the project sponsor and executive that this project is useful, so that they can continue in other phase. So the first phase is that they will use an existing data that all of them share the same and convert that data into FHIR. And this application will connect with this data. And the data that they decide to use is the claim data. In Thailand, we have 3 public insurance payers, the CSMBS for the government officer, the Social Security, and the universal coverage. In the end, there are 5 claim data sets to claim in this public payer. So they want to use this data set and convert it into a FHIR and store in the repository. So to facilitate this, we have developed the IG name claim consolidation profile to make this usable. So the end picture is like this. each medical school will establish the FHIR server in their control. Maybe it's in their data center or maybe it's in the cloud. Yeah, it depends on each hospital. But each of them will use an existing claim data that they already have and convert that data and store it in this FHIR server. And then they will have another app that connect with this server. So that is their approach in the first phase. And in the future, if this first phase successful, they will start incorporate more comprehensive clinical data into this data repository as well, and maybe other data as well. So in the implementation, this project is actually owned by the AeHIN University Hospital and the company named Clinicer. This company actually is also owned by this AeHIN hospital. This AeHIN hospital owns 51% of this company, and there's a bank in Thailand own another 49%. And currently it's being implemented by the company named NTT Data, and they use Microsoft Azure as its infrastructure. For the detailed architecture, we don't know either, because our responsibility is just for the profile and implementation guide of this project. In the detail, this is from the beginning of the project, but from what I heard, I heard that they changed quite a lot during the development. So I'm not sure what is an existing state, but currently they are implementing in this AeHIN hospital right now. So I want to show you a little bit of the claim data set. We have 5 claim data set, right? And 2 of them is pretty the same, so I put in the same column. And all of them share the visit information, the diagnosis information, the procedure information, and of course the financial information, because it's the claim data. But only some of them that have the medication data, and only this one have the laboratory data. But even they have, is not so well structured and doesn't have much detail. But as I said, this is a quick win project, so it might be usable in some basic use case for like finding a patient who have a specific disease or taking specific medication, something like that. So this is an example of one data set. It's a pretty long document, and in this data set there we have a lot of table, and in each table we have the name of the element and the description and the type and the more metadata. So what we do is that we convert this data set. We create we have 5 data set, right? So we create one Excel file for each data set, and in the this one to this one is the existing data in this PDF. So what we do is we create the next 2 columns. This one is for mapping from this element to FHIR, and this one is for general purpose, which is actually I don't think this is a good structure, but it's more like a internal communication tool. So we do it this way. It's used for remark, for terminology binding, for extension, so many things. Yeah, and we do this in all of the data element, which is in the end it around I think it's around 30 Excel sheet like this. Yeah. So we map every element into FHIR resource and resource type, and then we do this in all 5 data sets. So after this, we got the pool of FHIR element that we need to use and extension that need to be created. and also the identifier and terminology artifact that we have to use. After that, we organize it into profile and extension, and we have 18 profiles. And we pack it into implementation guide and publish at this website. So in the end, it looked like this one, the implementation guide. And yeah, it's just normal implementation guide actually. And when you come to each profile, you can see its detail, how the constraint and everything. And because this is more like a tool for communicating between us and NTT, so we don't put many detail, but in the real world situation, you should put more detail than this. Should be more detail about what condition to use this profile and many things, like other famous implementation guide. Yeah, and I want to be sidetracked a little bit about the way we map things. Yeah, in the course, there are one participant that he submit the assignment, and I think he did it very good. Yeah, he worked for this project, and the project, the way they map the structure is like this. And I think they arrange the structure is very good. I mean, the structure of how they have column about this, and this is about extension and the identifier and terminology thing. So, I mean, even if I have a chance to work in another project, I might copy the way he do this mapping. Yeah, so I think you should have a look at this. That is just a little bit of the sidetrack. The outcome is 18 profile, and most of them is in the financial area, right? Because it's the claim data, so it has a lot of financial data, but it also have some clinical data as well. The challenge that I think we face, the one thing that I think is the most problematic is the limitation of the code mapping. For example, in the original data set, they have an element that record information about the type of OPD visit. And both the CSOP and the e-claim have this element, this data field, and both of them bind to different code system. It's a local code in the data set. The first three is the same, but the last two is not the same, and it's not mappable, even with human, right? Because if this one is transferred from the EMS, yeah, it might be mappable to this one, visit and emergency service. But visit and emergency service doesn't mean that it has to be from the EMS, right? It might be from they can walk in or from other source. And for the telehealth, yeah, it might be mappable to other, but I think it's just strange from the beginning that telehealth is an OPD visit. that is anywhere. Telehealth can maybe mappable to other, but other cannot map to any other thing, right? So in the end, because we cannot map a data like this, so we have to keep it as it is in the profile. So it become like this, that one element that we need to keep an existing code system, and we cannot consolidate it into one value set, something like that. So, and it happened like this in a lot of profile. Yeah, so I think if like this one, I think if all of them from the beginning, they use some sort of the standard terminology, this problem will less happen. Or even if difficult to change the existing one, if today you have to create the new data set, you use standard. Since today, they will not have a problem in consolidating the data in the future like this. Yeah, so that is one challenge that we face. And another is that I think this implementation guys try to do too many things. Yeah. So they try to be everything. And I think they should make it more specific for a use case like or for clinical or for research or for claim data. Because right now, because most of the claim data here is too specific for the claim process, and it costs, and we try to map all of them to FHIR resource. In the end, it caused the profile to be too bloated, too many elements inside it. So if we focus only specific use case for this IG, I think it will be better in terms of the cleanliness and the way it's minimal. And also, even one thing that interests that I just know is that even if the same claim data set sent to same payer, it doesn't guarantee that the claim process will be the same. So yeah, for example, one hospital generate the new invoice number every time they send, regardless of its success or fail. And another hospital, they will see if the claim is success or not. If not, they use the same invoice number to send it again, something like that. So what happened is that it caused problem in converting into FHIR and cause data duplication. Yeah, so yeah, that I think the business analysis part is important in this case. And so because the claim process is a little bit different and the claim data is not so standard in the end, many hospitals here in the end, they say that maybe it's easier for them to just create the new data set that have that data that they don't need to care about the existing claim process, but focus only the data and send this to the FHIR server. Yeah, I don't know how this go for now, because the one responsible for implementing is NTT, but yeah, that is what I heard from them. Yeah, so that it is from what the limitation I faced in this project. And I think I already took a lot of time, more than I have allowed. So I think I think I should answer the question first, and then I will share it. I will over to the next speaker. So Manisha asked, share the claim IG. Oh, yeah. So I think for me, it doesn't have anything more. And yeah, over to you, Piraya.
Hi, thank you so much, Dr. So thank you for your comprehensive presentations. So next would be Dr. Chu and Li, or Dr. Billy from Taiwan.
Okay, so I'm Xu and Li, and representing the Standard and Interoperability Lab Taiwan, Smart Healthcare Center of Excellence Taiwan. And I just quick share some experience from the Taiwan side. So we established this lab about 5 years and collaborate with AeHIN. So the global goals is also follow the sustainable development goal as this good health and well-being. And we just try to support the hospital and the physician to design a lot of different AI model or the personal health management model for the prevention, protection, and the prediction. And the mission is to promote the knowledge exchange and collaborate with the Asia Pacific region and also in the Taiwan area, and the research and the innovation development inside of Taiwan. And we have we focus on the 4 major topics, A, B, C, D, which means AI, blockchain, cloud-based, and the data analysis. So I just quick introduce Taiwan's core IG right now. So since 2000 years, Taiwan started to exchange the EMR exchange center in the Taiwan national level. So all of the hospital which need because Taiwan have the national health insurance, so cover more than 99% of the Taiwan's people. So the hospital need to join this networking and share some specific EMR to the other hospital. So basically they need to prepare the EMR and the PAS image inside the hospital and then provide the index of the different patients' data to the national EEC center. And then when the reading hospital require the data, they need to provide the data directly to back to them. So for example, this is a very basic architecture here. So we hospital A, they need to, when they already got a patient, they need to provide the EMR index of the each patient's data, and then this index will transfer into the index server under the Ministry of Health. And then when the hospital B, they want to require the data, they will going to the index server, get the index, and then get the data from hospital A directly, which means the index server will not record any data. So based on this infrastructure, start from the last year in the 2022, our department of IT department in the Ministry of Health, they want to upgrade the whole system into the international standard way. So they just start to design the TW-COIL, so which means the Taiwan Core Implementation Guide. And then also basically in the list architecture, they have the four major documents that need to be prepared and then allow other hospitals to require. So including the medical image and the report and the blood testing and the discharge of abstract and the outpatient medical records. So based on this, and Taiwan our government tried to start to design the TW-COIL, and then based on the TW-COIL, they decided for EHR IG. So TW-COIL already announced, and then in the last year we designed the 10 core resources to share to the hospital to follow and design by their way. And also Ministry of Health and the Welfare already announced that FHIR will become the national standard for the data exchange between government, department, and the hospitals in the future. So which means the hospital need to provide the FHIR formats data to the Ministry of Health and also National Health Insurance for the client, the client. So last year we already designed the 10 TW core resources, and which is like 10 more most be used one. And also I think it's the same situation with the Thai. We just try to design the list website and then show to the, our hospital in the Taiwan, and then they can follow it. So based on this website, we will tell them which the data and the example value they need to put inside here. And then based on this one, we try to design more specific, like a cancer stage. So in the National Health Insurance, their requirements, we need to upload the cancer register information to them. So we just follow the data they already have and reference from the MCO to design the like a cancer register for the cancer stage resources, and then which data we need to put inside there. So for example, the cancer stage, we will follow the MCO design, put inside into the observation resource, and then we will derive the data format from the TW core observation. So the four EMR exchange center documents, including the discharge medical summary, patient medical record, lab testing report, medical image, and the study report. So we just decide we using the bundle and as a document to transfer it. So we just doing the same thing with the Thai. Like for example, we will using the Excel and then mapping each each column to the file formats and then transfer it into like this way. We will have a subgroup and the resource path, everything about that. And then we just announce it into, wait a moment. How should I do it? Yes, we just design it into kind of the website and then share to our hospital. And okay, we face the same situation. This example is the based on our client data. So I think the different to the Thai side is our have the national health insurance. So the client data always will in the same structure in the same format. But basically they in the past they using this as a kind of the XML format. So right now, if we want to change the data format in the hospital, they need to prepare their own hospital file server. So I think that is a more hardly to hospital to exchange all systems. So we just try to design not only the structure of the each document, but also design the converter, kind of a converter format, converter system to change the original data to the file formats, and then they can use it directly. So they can get more timing to establish their own system. So for example, in the list is a charge item, we will tell them, okay, so fixed value is billed, and then which column they need to put it here. So if they using our converter system, they just need to upload the data to our system, and then they will convert to the file format directly. But if they want to create it by themselves, in this part, we will tell them which column the data we need to put it here, and then make them more easy to design by their own system. So based on this one, okay, I think the time is a little bit more of control. So based on this one, we also designed for the National Biobank Consortium of the Taiwan. So we just try to design the research database, and then design every data will based on the patient journey to gather more different levels of data, and then change and then exchange to other people and for the analysis. So in this structure, we aggregate the data from the EHR via directly feed, so not need to transfer anymore, and also follow the M-code structure. So first stage, it only focus on the structured data, not and the second stage will focus on unstructured data like free text in the repo. And we get all data from the hospital side, and then they only need to upload the EHR data, and then we will transfer it to the data management platform inside the hospital. So yes. This is right now Taiwan's national levels currently status, and just a small AD. So we will hosting the MedInfo 2025 in Taiwan. Please join us. Thank you very much.
Thank you so much, Dr. Billy. So I think we don't have any questions.
Okay.
So we can proceed with the next speaker, Dr. Shaminda from Sri Lanka. So the floor is yours.
So I'm Dr. Shaminda from the Ministry of Health, Sri Lanka, and also part of the Health Informatics Society of Sri Lanka, which is hosting the Sri Lanka Strength and Interoperability Lab. So we are physically hosted by the Faculty of Medicine, University of Colombo, and I have to always stress we work very, collaboratively with the Ministry of Health. So most of the staff are from the Ministry of Health and are members of the Health Informatics Society of Sri Lanka. And this is our team. And we are actually working on two use cases currently. One is the National Electronic Health Record, which is like a womb to tomb health record for Sri Lankan citizens. And as part of that, we are trying to implement a patient identity management workflow. And we also do study some of these of OpenHIE reference technologies. And a colleague of mine, Dr. Chan, he made the Smart on Fire security wrapper for the FHIR server, which we are using currently in the Ministry of Health as well. And so what is this National Electronic Health Record? As I said, it's a womb-to-tomb electronic health record. We have many, like 3 main electronic medical records in many state sector hospitals, but they hold the data in silos. They're not transferred across. So what we want to do is we have defined this minimum set of data that we want to share across these different institutions, so that patient would have a continuous continuity of care record for themselves. And to do that, we have developed the National Digital Health Group Blueprint, and it's a very comprehensive one. But to achieve National Electronic Health Record, we have identified a thin slice of that. And these colored boxes are actually, pertain to what components needs to be there to achieve it. And it aligns very well with the OpenHIE architecture. And you might be familiar with some of these different OpenHIE components that are there in the architecture. And so how we are going to do it, I'll try to share my, yep. So the team started going through different electronic medical records in the country, and try to map the data elements that are captured from these electronic medical records with the minimum data set items that we have identified to be shared with the, with the National Electronic Health Record. And then in each of these electronic medical records, we try to capture what sort of data elements they are capturing and how it's coded. So because we don't use standard terminologies at present. So here in the gender, you have male, female, and some other system would have male, female, other. But then when it comes to HL7, the code system is a little bit different from this. So likewise, it differs from one to one. So what we try to do as our initial exercise was this, and also we try to identify FHIR path as well as the, mainly the profiles, the resources, as well as the FHIR paths where we want to encode this data in. And then we try to identify value sets, and we want to map with available terminologies such as CAL or ICD-10 or SNOMED GPS, and likewise. And then we have to, go through this profiling exercise. And so to do the profiling, we got some support from, on top of the FHIR training that we received from the AeHIN. We managed to secure some training from one of our international technical assistance teams from Canada. And we are using these open source tools for the profiling, but you have also commercial solutions, but to work collaboratively, they are relatively expensive. And I think as a challenge we identified during this process that, we actually do not comprehend what are the impact of some of the design choices that we make at the profiling, and how it's going to affect the overall, the NHR work downstream. So whether we want to do an extension, how that will affect in the longer run, because you don't want to do many many extensions, and also these value sets that go beyond the digital health. So you have to work with sometimes clinicians, and one of the issues that we identified was like, okay, the smoking status you have in some electronic medical records captured as yes or no, whereas in some others you capture it in more granularity. So we want to see whether like we want to map it to yes or no, and collect it in the National Electronic Health Record as just in that binary format, or whether you want taken it into sort of two observations, like smoking status detailed versus smoking status summary. So if we collect like that, then from our the health management information system side, we might be able to have a picture of the whole population as yes and no, but then you would have another cohort where you have more detailed information. So I think we don't know how things like that would affect our design choices at present downstream. So it's very important to share these experiences from different countries, so that we can actually make our choices better. And also we came across this difficulty in defining the value sets. As I said, you need expertise beyond the digital health, and it's very difficult to sometimes get consensus from the clinicians when you start doing these exercises. And from our experience, how we actually overcame some of these challenges is we have a dynamic team of about 14-15 people. So different groups actually got familiarized with the different aspects of work. Some some do the profiling work with the FOSS tools, and some study the data sets, and likewise. So it's because everybody can't do the same thing. I mean, it's quite a bit of a steep learning curve. And also we try to leverage on available examples, and I think the Malaysian Health Information Exchange profiles that are being published, that have been published recently, are quite good and quite comprehensive, and you can actually learn through that experience by more or less reverse engineering what they have done. And also I think one of the most important things is having this hands-on experience. So if you really know, if you have this infrastructure, like if you have OpenHI reference technologies running in your setup, you can actually try out different things and see how it impacts the overall work. So this is a very short presentation from me, and we have the published implementation guide in the GitHub. So I'll share the link at the end of the presentation. Thank you very much.
Thank you so much, Dr. Shuminda, for your experience in Sri Lanka. So our last speaker would be Dr. Miguel Altibe from CLAB. So please welcome Dr. Miguel.
Good evening, everyone. I'm Dr. Miguel Aljibe. I'm part of the Standards and Interoperability Lab of the University of the Philippines, Manila. So I'm here just going to share very quickly our experience in using the FHIR standard as well as the WHO SMART guidelines for us to build a disease registry system for HEPA for viral hepatitis. Okay, so first and foremost, I'd like to acknowledge actually the people who were behind this project. So this HEPA informatics project predated CLAB by at least a year, but eventually CLAB was an offshoot of this project. And a lot of the some of the informaticians who worked in these projects are actually now are in the audience. Okay, so maybe if some people have some very technical questions, I'll call on them. So a background about this project. In the Philippines, actually, hepatitis or liver disease is actually a very big problem. We have 10 million Filipinos living with hepatitis B and around 600,000 Filipinos living with hepatitis C. And these are just modeling estimates. These, we don't really know the exact number. And hepatitis is actually a leading cause of cirrhosis or liver failure, as well as liver cancer. And from a public health perspective, you need 3 numbers for you to be able to address the viral hepatitis, the spread of viral hepatitis in your country. The 3 numbers are that you need is the number of people who have the disease, the number of people who are taking treatment, and the number of people who are in remission, or basically the treatment worked on them. And the problem in the Philippines is we don't have the numbers. We don't know all 3 numbers. And when we started looking, where are these numbers? We found out that they are inside the EMRs, but the different EMRs in our country, we have at least maybe 5, 8 EMRs working in government institutions and probably 10 or 20 different EMRs working in private hospitals. They all use different data models, so they might use different variable names, but some may have the same meaning, or they may use the same terms but may have different meanings. So I think everyone's familiar with this problem. We can't aggregate and combine the data. So in this case, actually, a data dictionary, as suggested actually by a government administrative order, is one possible solution. So the government actually has some legal mandates that promote the establishment of harmonized databases and surveillance systems. So based on the need for us to be able to aggregate the data and the fact that there is legal support for it, this is what prompted the creation of this project on what we call the HEPA Informatics Project, or more formally, monitoring the chronic viral hepatitis treatment cascade through EMRs. So the goal of this project actually is to utilize FHIR to create a terminology system such that when you have your EMRs, whether they're from government or from the private sector, and they use different terms for hepatitis. Let's say one calls it hepatitis B, another system calls it viral hepatitis. When it goes through the terminology service, it's translated into the proper standard. And then you now can aggregate and combine the data. And when we pass it on to the national government, or for example, the health insurance company, there's now just one single term, hepatitis B, let's say, that's unambiguous and has shared meaning. This is the timeline of the project. It was supposed to be, I think, a 1-year project, but because FHIR and interoperability are very new concepts and techniques in the Philippines, we actually had to learn our way to completing this project. And one of the things that actually guided us was the WHO SMART guidelines. This is actually a set of steps. You can think of it as a recipe book that tells you how to turn your narrative policies, basically your paper, your PDF, the PDF files that the Ministry of Health creates. How do you turn it into digital systems that are interoperable without losing the intent of the policies, of the health policies in the first place? So one, it's a recipe book. Also, it's also a set of resources and best practices that countries can consult. So it just has these 5 steps are actually, the L1 focuses on the narrative. So this just focuses on studying the different laws and policies. L2 is focused on the forms, the health data forms. L3 to L5 are the technical side. So we'll go through each step quickly in this session. In the L1 step, we simply studied the National Viral Hepatitis Surveillance Initiative. It's simply the program or law of the government for viral hepatitis. So this provided us the basis or the guidelines. How should the system work to support the health workers? And level 2 is operational. We were now focused on the forms, and luckily for us, the Ministry of Health, as well as the Hepatology Society of the Philippines, already sort of have an idea of what kind of data should be collected. So we looked at 2 forms, the case report form and the care form. So the case report form is used whenever there's a patient who is newly diagnosed with hepatitis, and the care form is used to monitor patients with hepatitis who are undergoing treatment. So our terminology experts study these forms, they remove the duplicate elements, and then they looked at every data field and then simply mapped it to the different terminology standards like ICD-11, SNOMED, HL or HL7 FHIR extensions. And they presented it actually to the Hepatology Society and the government. And then they asked them to simply have a consensus, because there's no point in pushing for these standards if the people who will use it, who should use it, do not use it. So it was very important for us to get the hepatologists, the liver doctors, on board in this project. So once they agreed that these are the forms, these are the data fields that need to be collected, we will use, for example, SNOMED CT for this particular data field. We now moved on to the L3 level, which is creating the FHIR profiles and the implementation guide. And here, actually, the next step was to map the data dictionary we created to the appropriate FHIR element and resources. So you can see here, this is the form, the demographics part of the form. And we were, and our interop specialist was actually looking through the FHIR website and looking for the proper FHIR resource for each data field. And this is what this is just a summary of the mapping that they did for the case report form as well as for the care form. So on the case report form actually focused on patient encounter, family member history, observation, and organization resources. And the output here is a spreadsheet or Excel file. And then after the informatics people created this Excel file containing the FHIR mapping, we passed it on to our information technology specialist to create a FHIR structure definition resource that's in the JSON or XML format. So from a spreadsheet, we now turn it into a JSON format. And once we have the JSON file, we tested it using Postman API. And once we know that the Postman API is correct, the next step was to transform it into FHIR shorthand language. So FHIR shorthand is another programming language that is focused on the implementation guide. And then once we have the shorthand files or the fish files, it was uploaded into a Git repository. And eventually, using that, we developed our implementation guide. So the implementation guide is simply a set of rules of how a particular interoperability problem is addressed. And this is now the computable definition of this clinical narrative policies. It's now a digital format that can now be consumed by the EMRs. So actually the next step in L4 was to give it to the EMRs. So we had several what we call HEPACON. These are conferences. We got the different software providers in the Philippines. We actually had to teach them about FHIR and what FHIR is, and convince them of why they should give time and resource and programming work hours on it. It was very important that we got the Ministry of Health as well as the Department of Information and Communication Technology involved to show their support in this initiative. So eventually, we were able to hold a Datathon workshop in which we got several EMR providers in one room, and we were able to set up a SMILE CDR FHIR test server, and they were able to connect to this FHIR server and upload and the data that they have, actually synthetic patient data. But we were able to demonstrate to the government that even though there are different EMR providers with different data architectures, they can all connect to the FHIR server, and we can all combine the data and create a dashboard actually that aggregates all the data. So this is just an example of the dashboard. So we did not have actual patients that time. It's just only synthetic data. And eventually we passed it, all the artifacts we now passed on to the national government, hopefully for implementation on a bigger scale. So with that, thank you very much.
So thank you very much, Dr. Miguel. So I think we have two questions related to Philippines implementation of FHIR. The first one is from Ms. Zoe from Mongolia. So her question is, how would you know if it's hepatitis B or C only from viral hepatitis?
Okay. I think the report for the report form actually specifies, the case report form requires the doctor to really state if it is hepatitis C or B based on the clinical as well as the lab test. So it's the doctor who will say it's hepatitis B or C. So the system will just accept it. What we worked on was to find all the variations basically of how the different EMRs, for example, focusing on hepatitis C, how they use hepatitis C. Is it hepatitis C, hepatitis C plus, hepatitis positive, or something like that? And then that's what we worked on to make sure that the system can get all these different variations and translate it into one standard.
I see. Thank you so much. I think that another question I see someone's already answered. The Philippines is using ICD-10. So I think there are no questions on the chat by now. So actually, if anyone has questions, they can open your mic by now too.
Can I ask one question?
Yes, Miss Zoe.
Okay, thank you so much for the great presentation, and it's very helpful. So I was just wondering, so you said that you invited the EHR or EMR vendors and then taught them the FHIR standard. So does it mean that you asked for example, you showed 4 example EMR vendors, and so do they have to convert their data into a FHIR structure, and then so that the conversion is happening at the EMR level, right? There is no like conversion going on in between them. So
Okay. Yes. I think Paolo or my teammates Paolo and Bert, you can add additional details, but yes, it happens at the conversion is at the EMR level. Yes. So we give them the API and the mapping and all the other guidelines, so that there's not too much effort on their part, but some of the conversion happens at their level.
I see. Okay, thank you.
Thank you so much. So I think there's no questions by now, and we reached the top of the hour. So thank you. So thank you again for your presentations, many cohort leaders. So maybe 10 minutes is too short for your experience. So I think for the next session, we will see each author again. Okay, maybe you can take photo first from. Hope anyone can turn on camera shortly so we can take photo together.
Well, during this time, I would like to thank you again for Billy, Miguel, and Dr. Shamindra for presenting all of this presentation. I think it's very interesting and to see how you are doing in your country, and many of the things that you talk I find it quite relatable to me as well. I think it's good that we share experience like this. Maybe in the future, we share something like this again. Thank you.
Okay, thank you, everyone.
Thank you.
Thank you,
Dr. Rat, Lukwa, Mayank.
Thank you, everyone. Bye.
Mayank. Bye, Mayank.
Bye-bye.
Everyone.
Bye.
Goodbye.